Thank you so much for having me here today. Well, vascular cognitive impairment represents an important and potentially preventable part of the growing cognitive impairment challenge in the aging population. Clinical stroke or small vessel disease are only the tip of the iceberg. Before a clinical vascular damage occurs, there are several factors that we can prevent. And if the vascular damage occurs, still there are strategies that we can implement in secondary prevention to reduce the risk of further damage. But before we talk about the prevention, we need to understand a little bit the basis of vascular brain damage and its impact on cognition. In the past, there were many different definitions for vascular cognitive impairment. In 2017, the panelists from the Vascular Impairment of Cognition Classification Consensus Study proposed a classification for homogenize all these definitions. These pictures represent an example is extracted from the consensus guideline and show in a very schematic way the complexity of the vascular cognitive impairment. Can be mild or major depending on the severity of the symptoms, can be due to a clinical stroke, due to a small vessel disease, and can be in concurrence also with other neurodegenerative diseases, most frequently with Alzheimer's disease. The most recent and extended diagnostic criteria are the DSM-5 that put the spotlight in three important facts. One, the main affectation of the complex attention and executive functions, and my colleague will talk about them in the following session. Second, the temporal relationship with a cerebrovascular event within the first month after stroke, as pointed for the panelists. And the presence of a cerebrovascular disease. And here again, the vascular cognitive impairment panelists establish the brain magnetic resonance as the gold standard to identify it. In the following slides, I will briefly comment about the mechanism that caused the cognitive impairment in the landmark of the vascular brain damage, which are the small vessel disease and stroke. In the case of the small vessel disease, the mechanisms proposed include the damage to the brain cortex due to the axonal damage in the white matter and secondary degeneration with cortical thinning or cortical atrophy. Also, the damage directly to the microscopical vessel into the brain cortex that cause also cortical atrophy. And last but not least, the damage of the white matter tracts that negatively affects the connectivity among different brain areas. All of these pathways results in symptoms like cognitive decline and usually together with gait problems, apathy, depression, and extrapyramidal syndromes. Regarding stroke, behavioral and cognitive deficits reflects both structural damage at the site of the injury and widespread network dysfunction caused by structural, functional, and metabolic disconnection between these lesion areas and remote brain areas. Siegel et al. Described in 2016 how some cognitive symptoms, like for example, the visual memory and the verbal memory, can be better explained by a disruption in the global functional connectivity of the brain than the lesion itself in patients with a stroke. And for motor and visual deficits, the symptoms are better explained by the lesion itself. Normally, these lesions are seated in primary areas. So this exemplifies perfectly the way of work of the brain as a network in which higher connectivity function need a perfect coordination of association and heteromodal areas, and how a stroke can disrupt the whole network and cause cognitive decline. So now that we know how the vascular brain damage affects the cognition with a pure vascular damage, what causes the vascular brain damage? Well, the simple answer is vascular risk factors, such as hypertension, diabetes, smoke, or the body mass index, has been pointed as the main causes in epidemiological studies. However, the weight of genetic, lifestyle, socioeconomical factors, and most importantly, the interaction among them is crucial to really understand how the pathophysiology works and to have a good prevention strategy. For example, for small vessel disease, this is a recent study published on Nature in which the researchers first identified 27 risk loci related with the presence of a small vessel disease measured as the burden of white matter hyperintensities using a US approach. Then they investigated the shared genetic variation between the white matter hyperintensities burden and the vascular risk factors. And they found that within these 27 locis, these 20 represented here were also associated with at least one vascular risk factor, mostly with blood pressure. And some of the shared genes, as marked here with an asterisk, could act as protectors when the vascular factor is present. So this is an example of the complexity of the relationship between the vascular risk factors and the brain health and the brain damage, and also exemplifies the necessity to individualize the prevention strategies. For stroke, this is also a recent study involving 32 countries, the Interstroke study. And here the investigator found that, again, hypertension and smoking were associated with 2 to 5 higher risk of incident stroke. But also, and not surprisingly, they found that psychosocial factors have an important weight in the risk of stroke. And have a healthy diet based on the Mediterranean diet, and practice regular physical activity can be protector factors for developing a stroke late in life. So all these vascular risk factors are related with the vascular brain damage, which we know that cause cognitive impairment. But are they also related with cognitions as mediators to develop dementia of any cause? Well, this is a really nice study conducted with the UK Biobank cohort in which researchers analyzed the presence of vascular risk factors, both biological and lifestyle, in the development of further cognitive impairment. So the incidence of dementia after 12 years of follow-up was higher in those participants with poor vascular health in both categories, biological and lifestyle. After adjustment for education, sex, age, and lifestyle for biological traits and vice versa, only the biological score remains significantly associated with the incidence of dementia, being the systolic blood pressure and the levels of glycated hemoglobin related with dementia within these biological traits. But we know that even in a large cohort, it is hard to prove causality with observational studies. So the researchers also did a Mendelian randomization analysis showing that only the systolic blood pressure was related with dementia after the follow-up. So far, the interaction between vascular risk factors and brain health and cognition seems a little more tricky than previously thought, but it seems that hypertension could be especially related with both the risk to develop small vessel disease or a stroke and as a mediator for the risk of cognitive impairment of any cause. So the answer to the question, what we can do to prevent vascular brain damage, seems simple: treat hypertension, right? Well, in the past, several clinical trials were designed to treat one risk factor at a time in order to reduce the risk of cognitive decline. But the majority of them failed in demonstrate that treating one vascular risk factors with a pill or two means to reduce cognitive decline. This recent meta-analysis resumes the results of the most important clinical trials in which participants with hypertension were randomized to one group, treat the high blood pressure intensively, and other group or to other group with more relaxed goals. Only 2 studies demonstrated that the intense reduction of blood pressure reduced the risk of cognitive decline, with not so large sample size, the Sprint Mine and the Progress. But overall, in this meta-analysis, treating intensively the blood pressure will reduce the risk of cognitive decline, but only in 0.7%, which is not really concordant with the weight of the hypertension considered in previous epidemiological studies for the development of vascular brain damage. So the new approaches that actually prove their success preventing or improving cognitions are the multidisciplinary interventions. This is the FINGER clinical trial developed in Finland, and the researchers designed a 2-year multidisciplinary intervention targeting the diet, exercise, cognitive training, social activities, and changes in lifestyle related with vascular health. And after 2 years, participants in the intervention group demonstrate a 25% more improvement in global cognition, but most importantly, an 80% of improvement in executive functions and 150% of more improvement on processing speed compared with the control group. These two cognitive domains are mostly related with a vascular cognitive decline rather than the memory domains, normally more related with neurodegenerative diseases. And for memory, they didn't find any difference between groups for the intervention. And also the risk of cognitive decline was 1.3 times higher in the control group. So the key seems to be the development of multidimensional interventions to cover the multiple dimensions of the people. This recent study shows the importance of the environment during childhood in late life cognition, proving that the place of birth and the socioeconomic factors matter for both the presence of vascular risk factors and the cognition late in life. So the participant of this study that born at the stroke bell in USA presented higher poor childhood rates, higher childhood hunger, and less percentage of obtain a college degree. The vascular risk factors were higher for those participants who born in the stroke bell independently of the socioeconomic resources, and later cognition in life was associated with the place of birth, also independently of the vascular risk factors or the socioeconomic status, meaning that the childhood experience in brain health is important, and we have to consider this in order to design future studies and to help to reduce inequity to do meaningful prevention strategies. The things that we can do in secondary prevention to reduce the risk of developed cognitive decline after a stroke or when a small vessel disease is diagnosed are so similar to those in primary prevention, including here the pharmacological treatment, especially for avoid a stroke recurrence and rehabilitation strategies, because the drugs used for other neurodegenerative diseases seems to be not so effective for vascular cognitive impairment. But the lifestyle still has a key role to prevent, for example, another stroke. And this is a clinical trial published 10 years ago, but still the cerebrovascular neurologists follow this recommendation of the study. In patients that had a stroke due to an intracranial stenosis, the medical management, including here the change in the lifestyle, treating obesity, prescribing physical exercise, smoke cessation, demonstrated to be more effective preventing another stroke, a stroke recurrence, than treat the intracranial stenosis with a stent. And last, talking about rehabilitation and further strategies, the importance to remain in a cognitively stimulating environment after a suffer a stroke to prevent a possible cognitive decline and to improve the sequels of the stroke. So animal models showed that those mice that remain in an enriched environment after stroke had more dendritic growth than those mice that remain in a regular cage. So for humans, the equivalent of being in an enriched cage could be to be involved in artistic and cultural activities, involved in activities in nature, exercise, as much cognitively stimulating as possible. So in conclusions, vascular brain health is an important part of aging. The cognitive pattern of vascular cognitive impairment are different from other neurodegenerative diseases. Promote a holistic view to study the pathophysiology of vascular brain damage is the key to really understand what is happening. And of course, multidisciplinary interventions rather than one risk factor interventions are needed in both primary and secondary prevention. Thank you.
That's great. Thank you very much, Dr. Gutiérrez Zúñiga. That was a very interesting talk. We have an opportunity for questions and answers at the end. I know nothing has come in at the moment, so people can feel free to use the chat and Q&A buttons there on their screens if they have any particular questions. Just a comment there, very interesting. Yeah, great. So there seems to be people have enjoyed that talk. Great, so we'll now move on to our next speaker, who's Cathy McHale, Candidate Advanced Nurse Practitioner at the Institute of Memory and Cognition in Tallaght University Hospital. So Cathy's going to talk about common symptoms and challenges of vascular dementia. So over to you, Cathy.
Hi, how are you? Really happy to be part of this, and I think it's a really important discussion because we talk a lot about Alzheimer's disease, but maybe we don't talk as much about vascular dementia. And I think for families, it's a useful thing to raise the profile of the conversation a little bit so that they can try to live with the symptoms and to make a way forward. So I suppose from my point of view, I'm a nurse, I'm a candidate advanced nurse practitioner. I work in the Institute of Memory and Cognition in Tallaght University Hospital. I've been here for many years, but I suppose it's only in the last number of years that we have had a memory clinic since 2014. So, you know, dealing with this disease a lot down through the years. So mine, a little bit of a different slant, but hopefully you'll get something from it. I'm trying to move my slides and nothing's happening. Okay, so I actually am going to skip through some of the first few because I think Raquel has managed to really comprehensively deal with what vascular dementia actually is, but maybe just what common signs that we tend to see in our memory service. I suppose myself and my colleague Joshi would tend to see patients at the first point of contact and do an in-depth neuropsychological profile, but also take a full history from family and the person themselves. But I will talk about symptoms, and I think that's what I wanted to zone in on today. And then of course I could be here all year talking about symptoms because they're so broad and varied. So I'm going to focus on cognition, how memory can be affected in vascular dementia, and apathy, because that's a symptom that I see a lot. That's something that family tend to struggle with, and it's something that maybe we don't talk about as much as we do depression and brain health, which has already been covered, but I will go into it again. I know my colleague Tim Duclo and Joshi Duki already covered this in another session, so I will dip into it. And then I suppose approaches to supporting someone through a post-diagnostic pathway. So I'm going to skip a few of these initial slides. So second most common cause of age-related dementia, I suppose attributing to vascular causes accounts for roughly 20% of all dementias with you know, so all the literature will be very much paralleling with stroke literature, and it's a very complex disease. I won't go into criteria because I think we've already covered that, but I suppose what will we see when we see somebody with a profile of memory issues? Oftentimes it will turn out to be something like an Alzheimer's type process, an insidious picture. You know, the symptoms evolve over a long period of time, slowly. When we see somebody with a vascular dementia picture, it can be a little bit more different. It can be, you know, changes can happen quite quickly. So the story is a little bit different. It needs a lot of teasing out. Memory impairment is not necessarily part of the picture, but executive function certainly is. And I'll talk about that in a few minutes. So we do see the stereotypical stepwise progression. Is it always like that? No. It can be fluctuating course. There can be prolonged plateaus. So it is difficult for family. When do you push a panic button? When do you go in and get a screening done? Oftentimes memory is not a part of it. So if you think dementia is memory related, you probably won't come through. So again, yeah, so I know that Raquel has mentioned some of the risks, but I think it is useful to actually look at them. So age obviously is an independent factor. There's increased arterial stiffness relating to changes in elastin, collagen levels, and changes of the arterial walls themselves. Increased risk of vascular dementia and stroke, and increased risk of dementia post-stroke. And one study would have said incidence increases every 5.3 years. And as Raquel has said, male, lower education, genetics is in there, but also depression. You know, chicken and egg is always connected with dementia to some extent, but certainly we would see that the finding of a link, late life depression, and pathological findings. So brain white matter damage and other subcortical lesions are increased in late life depression. So then, and I know that we've mentioned this already, but patients with long-term diabetes have increased risk of VCI, vascular cognitive impairment, and vascular dementia. So that blood, you know, that glycemic control helps to prevent microvascular and macrovascular events. So hypertension, mentioned, but very, very important in this story, in middle age can cause vascular dementia in later life or expedite progression, induces hippocampal atrophy and white matter damage. So midlife obesity has been identified as being very important. So the risk of vascular dementia in a patient with a BMI of greater than 30 would be about 5-fold increased in some studies, and being overweight in midlife, so that's BMI of between 25, greater than 25 but less than 30, would increase your risk 2-fold. So very, very important to consider that. Metabolic syndrome, I point out because it's an unfortunate cluster of conditions that occur together, increasing your risk of heart disease, stroke, type 2 diabetes, and these conditions including, I suppose, hypertension, raised blood sugar, and excess body fat around the waist, which I've mentioned, and abnormal cholesterol and triglyceride levels. Sorry, my slides are sticking. Hope that this will move.
Yeah, sometimes that can happen on Zoom, Cathy. Yeah, usually it kicks
Here we
in
go.
eventually. Yeah,
yes.
Great.
So I suppose talking about the symptoms of vascular dementia, it is so broad. Neurological symptoms, I won't go into these all in depth, but certainly a gait and balance issue that we see with patients, slow shuffling gait, marcha petit pas, short stride length, and the issues that bring people to us, and we would regularly send people through to the day hospital for would be reduced balance and falling. So, you know, very important to get an early comprehensive geriatric assessment for the older person, but also to link in with OTs and physios in the community. It's for all families really. Features of vascular Parkinsonism we see as well, so rigidity, bradykinesia, which is slowed movement. The urinary issues can be very, very troublesome as well for patients, and just that stroke piece, which I know Raquel has covered, but I suppose we would see with the more severe large artery strokes, disorders of language, reduced visuospatial abilities, and those cortical syndromes of aphasia, apraxia, amnesia. So I focused on these two symptoms because I obviously don't have time to go into depth in all of them, but I think the way in which people use their memory is a useful way to describe vascular dementia for families. And so what do we see? We see, I suppose, a mild cognitive impairment sort of feel to their memory patterns, but they certainly do have disordered executive function, which means, I suppose, difficulty solving tasks, planning, coordinating, difficulty sequencing, and particularly solving unstructured tasks, reduced planning skills, and a marked attentional issue. So vascular dementia does come with huge issues around attention, slow processing speed, and so these are the things that may impair someone at home when they're trying to carry out their normal day-to-day duties. The other one that I'm going to pull from the neuropsychiatric changes is apathy, because I think it is something that families do struggle with. And I have a constellation because I think it is a constellation most of the time. So just one of the tests that we use, it's called the R-bands, and what it does is it breaks memory out into chunks. So, I mean, we're always trying to get that message across. It isn't just about memory. Dementia is about many cognition domains. So immediate memory, visuospatial, language attention, and delayed memory. So just looking at somebody sample profile of a 73-year-old man, a strong premorbid function, business and law, so estimated premorbid IQ of 120 with 19 years of education. So this man comes in with, I suppose, a history and a story that we get from a family of rapid forgetting, of losing information quickly. And so this is really like an Alzheimer's type picture, whereby you'd have a reduced immediate memory, you would have an issue with language often, but you have a markedly reduced delayed memory. So giving someone information, after a period of time, they lose it. But if you look at a vascular picture, then you see something very different. You see almost an inversion of the shape. And that is because they have huge issues, and I would say huge and always huge, but they have visuospatial issues. What might that look like at home? The person may be falling. The person may have issues trying to measure distance to objects. They may have issues parking their car. So these are the things that you may see. Language not so impaired, but attention is usually a component. And delayed memory not in the earlier stages, but later on we may see that. So again, we see these profiles. Now they're not written in stone. There's obviously lots of reasons why people will underperform, but it's a useful thing to break them out. So if you see patients which regularly would have Alzheimer's disease process with a vascular contribution. So they have those plaques and tangles, they have all of the proteins, but they also have this blood flow issue. And what I wanted, I suppose, to show families and people themselves is that it is quite a flat profile, whereby they will have impairment across all their domains. And it becomes a very complex memory problem, really. And it becomes a situation where communication is really paramount. So Alzheimer's disease, if you were looking at a very simple model of memory, how does it affect it? You encode information, we take information in through our senses, then you store it, and then you retrieve it out again. So if you were to look at it in 3 steps. So Alzheimer's disease impacts that storage piece in the middle. It's a hippocampal syndrome, and it leads to storage failures, inefficient learning, and rapid forgetting. But if you were to look at vascular dementia, then what does that do? It's a little bit different. You're really looking at a problem in that encoding stage because their attention is so hampered. And then you're looking at issues trying to pull information back out again. So you've told them something and you're wondering where it is. They're wondering themselves. They go in to get it. It's not there. So, you know, the constellation of symptoms really does affect day-to-day use of memory. The other one that I wanted to talk about, I don't know time-wise, hopefully I'll have enough time, but apathy is a big problem for families sometimes. And the story will be that the person just has switched off from their life, really. They can't seem to care about things. And I think it's a lack of concern about their own problems, but problems of others as well. Less curious about new things, seeming not to respond to things in the family, less inclined to make plans. So they know they need to do something, but they need a lot of prompting and coaxing to do things. So it's a reduced motivation that can regularly look like depression, but actually isn't. Because it has very similar features. So it can get worse when somebody withdraws. They stop doing things they used to do. They lose their confidence in their abilities, and it kind of causes a cycle of sense of failure to take action, and then they feel that they don't have control, and then they lose the ability, which leads to further inactivity. So it's a really important symptom for families to understand, I suppose. People regularly come in and there's a bit of angst. They feel there's a laziness, and it's in the literature. It's been documented as an associated term. So it's just really important to know that that is relating to specific brain changes. And I actually tried to find the specific area of the brain, and I found about 6. So it certainly is a really complex symptom that people have to manage. So how do we manage it? Not really drug related, you know, as I said, unlike depression, it's a bit more complex, but studies have shown that engaging in life activities, music therapy, art therapy, cognitive stimulation can all help. Family training I mentioned, but making a routine can help. So using assistive technology and task assistance, then for some people, they will actually start a task if they're given a little bit of prompting, and then maybe you just do part of it for them. I suppose there is a sense of taking over a little bit sometimes to really help people, but it's best to sort of let them do what they can do, and also just keeping up energy levels, promoting sleep and rest, getting exercise. They're really important things. So brain health, Raquel has gone into in great detail. I know we've done this already, but I suppose the big message is potentially modifiable is 40%. So if we look at this on a kind of a lifespan model, we're looking midlife. So these are the risks: hearing loss, traumatic brain injury, hypertension, alcohol, and obesity. There is something we can do about these things. And then if we look at later life, then smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. So this is a beautiful piece of work that was done by Lancet, and I cobble it out every time I do a talk because it's so important. So I suppose, what do we do? What can we do? In Tallaght, just breaking, I suppose Raquel did the macro view of brain health and what we should be doing, but to look at how we, I suppose, operationalize it, we set up a designated brain health clinic, whereby somebody comes through with anybody with subjective memory complaints or MCI will come through, and they will have a personalized prevention plan put in place. And as I said, I know that Tim and Joshie have already gone through this, but modification of vascular risks, looking at exercise, diet, all of the things we've talked about, but adding in other extra pieces that are related to dementia. So sleep hygiene, very, very important. Hearing and vision, very important. So we try to, I suppose, take the Lancet Commission, take all the advice from the WHO and put them together and create something that would actually make a difference. I mean, as nurses, and especially AMPs, I suppose you would be having lots of conversations with patients about brain health and about their lifestyle. Patients getting multiple messages through different places, from ED to endocrinology, about smoking cessation, about alcohol cessation. But this is a nice place where you can actually just show them that they can make a difference in their own lives and they can take some responsibility. And it isn't about blame, it's actually about enabling people, giving them very solid signposting to things like quit.ie, and just understanding, I suppose, the place that people can be in, because I think it must be multimodal, and we know that from all of the finger studies. It must be multiple different aspects of your life that you try to change. So I think just it's useful to talk about the post-diagnostic experience for someone with vascular dementia. It should be no different from somebody with Alzheimer's disease, but we do think family training is really important, especially in vascular dementia, to understand the symptoms, to understand that apathy isn't intentional, and just to really understand that you need to look after yourself. It is a very challenging type of dementia to support somebody through. Lots of peaks and troughs, lots of things changing very quickly, lots of personality differences. So we would do an initial signposting to public health, to the MDT. We do the piece around forward planning. So we send people towards citizens information, ASI, and then it's really a look at getting people to live well. So the cultural quarter here in Tallaght is phenomenal. So we have these beautiful cafes, we have the civic theatre, and art and music are so powerful for dementia. And I know we have an expert in both caring but also in musical realms, so I'm not going to go near that, but art, absolutely, and the national choir. So we would send people through to anything that we feel might be useful for them to live well, and the community and memory technology resource rooms are really lovely for people who are having memory issues, especially those mixed pattern ones that I talked about. So I suppose understandtogether.ie is a lovely website, dementiapathways.ie, and the Alzheimer's Society website as well. Final thoughts, it's a really complex syndrome, it really is, and no one person is the same, and every person deserves an accurate diagnosis and post-diagnostic support, and families should be offered training and support. And we have our own training course that we run across 6 weeks for our families, and we go through delirium, we go through all the risks that they can face along the way, and also we also instill brain health. So we're telling families about brain health as well as the person himself, trying to hit those earlier generations and get people early. So it's never too late to improve brain health. So that's it. Thank you so much.
That's great. Thanks very much, Cathy. And a nice positive note to finish on. That was a very interesting talk. So we have a few questions coming in, but we might just wait until the end and answer them all in one go. But I know some of the speakers will be typing in some answers as we go along as well. So for now, we'll move on to our final speaker, who's Mike Hanrahan. And Cathy alluded there to the fact that he has some musical talents. So Mike is a professional musician. And but today he's going to talk to us. Well, we will get a bit of music from him, but he's going to talk to us about talk to us about his personal experience of a family member living with vascular dementia. So over to you, Mike.
Thank you very much, Carol. And I'm kind of in awe after listening to Cathy and Raquel. It's when I was asked to be part of this, my first question was, I don't know why I'm being asked. And then there was this whole idea of not knowing got into my head, and I started looking at how we as a society, we don't know very much about caring for dementia. And my mum was diagnosed, well, it's 11 years ago now. She was diagnosed 8 years ago. She died last year, but we reckon she took on the first stages of dementia about 11 years ago. So we had no idea what was going on. So this whole notion of not knowing is very much part of what I'm going to talk about today, because as carers, we don't know, there's a not knowing of how you deal with a diagnosis at such an early stage for a family who have no experience of this. There's not knowing why there's such a rapid decrease in her cognitive skills from a mum and a person you knew and loved so much. Her final 4 years were confined to a wheelchair, which brought a whole different set of conditions for her lifestyle. And her final year was basically in silence. We as a family, with not knowing what was wrong, not knowing what we should do, not knowing the right question to ask, not knowing why your loved one gets so angry, why you get so angry, not knowing why your loved one loses so much patience, why do you lose patience in return, and not knowing how to communicate with your family, not knowing if you're doing the right thing, not knowing how to bring your family together as a unit, because we have a big family, so it disintegrated over the years. And that was one of the things that when Mum died we're still trying to bring all those pieces back together, because we had nowhere to go. And it's the one thing I noticed from being involved in the last 12 months with dementia and dementia care and trying to move forward and be involved as an artist, is that there is no hub for us to go to. And it's so great to hear Cathy talk about the memory hub in Tallaght. I really wish I had Cathy around 11 years ago for our family, or with something similar. But I think this is the way forward. The way forward is to make a more inclusive society and bring people together so that we as carers can come in and discuss our issues, and it helps us as well to deal with the problems we have with our loved ones. During one visit to my mum, it was one of those horrific window visits where it was towards the end of her life, and we were arrived into the care home, a beautiful care home in Ennis in County Clare, and the window is between us. The poor nurse is struggling to communicate because Mum has no eyesight. So I got in my car with my wife and we drove back to Dublin. We were so upset about the experience. I was so upset I wrote a song. And the song I wrote was called A River Rolls On. And I viewed my mum's life as a river that started way up high in a mountain, and she found her stream right down into the valley, and she nurtured everybody. She maneuvered her way around the oak tree, the tough things in life. She maneuvered her way around all the other aspects, met the birds and bees and looked after everybody and nurtured life. And she was finding her way to her ocean. And my wish in the song was, I really want you to find your ocean now. That's what the essence of the song was. And there was 2 lines in the song, and it's like they caused me so much grief, even still to this day, but I had to write them. And it was like, the lines were, go now, your time here is done. Time to stop lingering on and on. And even when I was recording it, I broke down because I knew this was me making an affirmation of my own sense of guilt and struggle with me wishing my mum to see the end of her life. And that was us from viewing my mum's illness at such a close range. And I still, to this day, when I sing this song, these 2 lines still cause me a bit of trouble inside. When my mum eventually died last year, I sang the song. I was left alone in the church choir singing this song, just to me, my guitar and my mum. And that was the beginning of my healing process. And it continues. But part of my healing process was a promise to my mother to go and help people who are caring for vascular dementia, who are caring for dementia, for Alzheimer's, and for people who are caring for the carers, the nurses, the doctors, the neurosurgeons. And that is my life goal, is to dedicate my time and my efforts to get the discussion going in Ireland, because we need to talk dementia. When I wrote the song, I rang my friends in the Forget-Me-Nots choir. The Forget-Me-Nots choir are probably one of the most incredible bunch of people I've ever met in my life. They started years ago, about 6 or 7 years ago, when 3 sisters wanted to care for their mum, who was in the early stages of dementia, and they wanted to give her somewhere outlet to sing and meet other people. And suddenly the choir grew, and to this day, there's a waiting list for this choir. So I went to the choir and I said, I have this song. I was introduced to them through Brendan Grace, my friend Brendan Grace, who did so much work with them. And we recorded the song during lockdown. We went into the studio, myself and my friend Al Doc, when we could. And then the choir recorded their lines into phones, into iPads, new technology for them. For so many of them, it was new technology, and they did it. And they achieved this amazing project called A River Rolls On. And we recorded it and we released it. And it was played in all radio stations around Ireland. And I was invited to speak to a lot of the radio stations. And that's where I discovered there's a whole community out there of people like me who hadn't a chance to speak about their life in care. And the amount of words, positive words I got back from people saying how great it is to talk about these things, about the things that we were afraid to talk about, because in my history, in our history of our country, there was a great notion that if somebody was losing their ability to think and operate their brain, it was known as, well, they were doting and they were put into the corner and grand, we look after them. Whereas it's not so anymore, thank God. I was invited, as a result of the song, I was invited to be the ambassador for Age Friendly Ireland in County Clare. And I suddenly discovered in County Clare, in my old hometown where I grew up, the amount of work that's going on from Age Friendly to develop a better society, a more inclusive society, independent living, independent thinking is immense. And I'm so delighted that I've got involved in this, because now there are ambassadors all over the country, and we will meet this year and we will start exchanging ideas. For me, my contribution would be my music and my experience. I was very lucky to work with Magda Kazmarska, a GBHI fellow who is a creative dancer. And I saw firsthand how she can go into a room online and create these amazing moments for people suffering with dementia through dance and through entertainment. And for me, it's all about moments. For me, I discovered with my mum that it wasn't about trying to make her life better, prolonged. It was all about those special moments. Initially, we'd go down and we'd sing songs for her, and we'd sing songs for all the people in the care home and have a concert that was great fun. And then myself and my brother Kieran would go down to a silent mother in her room, and we'd just play it for an hour and a half. And the reaction we got from her was in her eyes. And that made us communicate. That was our communication. We saw how she still had that connection with music. And I believe that is the connection that I can give and I want to give in future. And it's about those moments, the moments in time when we can create something special for the people we care. I'm currently caring for my mother-in-law along with my in-law family, and she's in a care home, and we started speaking Irish. I started learning Irish last year. And so in our sessions, we take the Duolingo in and we talk Irish to her, and the amount of memory she has in our banks of her schooling Irish is immense. So it means where the hour was really tough, and it is tough as a carer to go in and create something for an hour and a half. No, it's not. It's so much fun because we're learning Irish together and speaking and having a bit of fun. So we leave the care home and we're on a high, because we know we've given her a special kind of moment or two there to give her a bit of a buzz, which she deserves. And we all deserve a bit of a buzz. And I think that's really what I'm on about. I'm going to sing the song for you. Of course, I'll sing the song for you, and then I'll shut up. But I just want to make sure that I'm here to help anybody who needs my help within your community. I'm so impressed with listening to what I've heard this morning. I really wish you were there 10 or 11 years ago, but you're there now. And I think we need to spread that word around. I am certainly be doing it as in my ambassadorial role in County Clare, and with the other ambassadors around the country. We'll be spreading this great word that there is hope now. And it's time for us to give those moments, special moments, to the people who suffer from brain health. So I really thank you so much, Carol, for inviting me here. I feel like I'm kind of, I don't know, I don't feel I should be here in halfway.
Not at all, Mike, not at all.
But, because it's such a company, but I'll try and sing a song, and forgive me, this is a computer, and there may be latency issues and sounds, but so I'll play a low guitar, and maybe the words might just tell my story. So thank you very much. The river rolls on. The river rolls on to the sea, far away from the high mountain stream, to that place where you long to be. A river rolls on to the sea, down through the hills and the glade. You roll on through sunshine and rain, round the oak and the willow you came. Even the birds sing your name. They're singing the song for you now. In their hearts you forever live on and on. Yeah, they sing of your grace and your joy as you gently go rolling by. With a tear and a smile, and a river falls to the sea. By the shoreline, ocean breeze, it's there you will set your heart free, where the river falls to the sea. So go now, your time here is done. Time to stop lingering on, and you'll soon feel the soft ocean breeze, where the river falls to the sea. It's where you long to be now, so roll on, yeah, roll on, and soon we'll be with you there, to breathe in the salt in the air, remember the moments we shared. So go set your sail and sail away, you sail away, you sail away, sail away. We're singing this song for you now, in our hearts you forever live on and on. Yeah, we sing of your grace and your joy as you gently go rolling by. With that tear and that smile, a river rolls on to the sea, a river rolls on to the sea, a river rolls on to the sea, and a river falls to the sea. Thank you.
That was beautiful, Mike. Really beautiful. And we just have to imagine the 120 other applauses around the country. And actually, we usually get a bit of an international audience. So we'll have to imagine them around the globe clapping, because that really was beautiful. I managed to hold back the tears just because I know I have to speak now, but very, very moving. And I know there's a lot of a lot of positive comments coming through there, and we really appreciate your input today. I know some comments are coming in there that people really like to hear from people like yourself with that kind of lived experience. So, and you spoke about it so eloquently as well, and great that you're doing all that ambassador work, which is so important. So it's very much a team effort, you know, from people like, you know, the three of you on the call this morning. I think we have to tackle this disease from all angles. So great to hear from you all. Now back to some of the questions and answers. I know there was some questions coming through there, and thanks to Raquel and Cathy for answering most of those. There was a question about one of the trickier aspects of providing information on vascular dementia is conveying a sense of whether a person who has had a stroke and has cognitive impairment is likely to recover some or all of their cognitive function, or if they have a progressive irreversible dementia. I don't know if anyone wants to make comments on that.
From my end, we would see patients post-stroke, not probably that often because our colleagues are working within that area who would have a lot of expertise around dementia, but we do see patients and we do bring them in and we do neuropsychological testing on them to just have a look and see what the origin of their issues is. So sometimes it can be a bit complex because I think people are so different. Their deficits are so different. So you really need to take it case by case. For some, there can be improvement. For others, it just depends on the processes that are going on. You know, if somebody has an underlying other issue going on, for example, Alzheimer's disease, then it will become a complex thing. But yeah, I don't know, Raquel, if you want to say anything.
Yeah, sure. For post-stroke cognitive impairment, we have, I think that you are referring, Carol, to the question from Simon Wheeler that talk about the post-stroke cognitive rehabilitation that is so neglected. I totally agree with you, Simon. One of the problems for post-stroke cognitive decline is it's hard to diagnose with the neuropsychological batteries that are made for neurodegenerative diseases, because normally patient with a stroke and also with a cognitive impairment has neglect, has aphasia in some degree, has also hemianopsia, has motor impairment, and other symptoms that can mask the cognitive decline. So in the past, there are some pilot clinical trials that actually prove that the cognitive rehabilitation help to recover the cognitive function after a stroke. But the thing is, we are not totally diagnosing all the cases of post-stroke cognitive impairment. And when you put together in a meta-analysis, and the Cochrane review has a recent meta-analysis about the cognitive rehabilitation after a stroke, you realize that the majority of cognitive programs were developed for only one cognitive domain at once, right? And with a stroke, you have an impairment in the global cognition. So even when there are some studies that point that is helpful, we don't have a large clinical trial that actually prove that cognitive rehabilitation improves post-stroke cognitive impairment. So normally these kind of therapies are not included in the public health systems. So yes, there is still room for improvement. We have some proofs that with cognitive rehabilitation, these patients can improve their cognitive function, because, you know, after a stroke, we have brain plasticity and brain repair mechanism, but these mechanisms need to be triggered by rehabilitation, as for example, speech therapy for aphasia or physiotherapy for motor impairment, right? I hope this answers your questions. I am totally with you, Simon. Cognitive rehabilitation, it is also really neglected, for example, in Spain, where I developed my career as a neurologist.
Yeah, and I think things improved a little bit in Ireland here, but probably with COVID, I know there's online options, but COVID has interrupted a lot of those face-to-face group interventions. Great. So thank you for answering that, Raquel. So another question, how would you recommend encouraging a family member to go for a diagnosis if they don't want to? So I don't know, Cathy, you might,
Yeah, it is a big challenge, and I know I saw a lady only recently, and it had taken them a year to convince her to come through, and it's a really personal thing, isn't it? And oftentimes the person will have enough insight to make them quite anxious, and obviously we see a lot of anxiety anyway, so it is a very difficult time. I suppose coming together as a family and trying to discuss what's the best approach sometimes works, having everybody on the same page. Something like, I mean, we have a memory hut here, which has been kiboshed by COVID, but hopefully we'll be back soon. You know, a way of going to a stand where you look at leaflets, and Mike and I were discussing this at the beginning, and it's a conversation starter. You know, do you think it might be useful for you to get your memory screened? Sometimes having a quick chat with GP if you really have concerns. But I think there's a right time to do it sometimes. And it isn't for, you know, every family's different. It is a big challenge. It really is. Sometimes it's usually one big event that happens. Somebody gets lost, they can't find their car, you know, so regularly it'll be one event that will start things rolling. But for some families it trundles along, and it can be really challenging. Yeah, it can be really challenging.
Just to point, it is in vascular dementia as well as in Alzheimer's disease, there are a component of unaware of the patient. Like sometimes the patient lost this kind of insights. The patient are not aware that there is something wrong with them. So it is kind of tricky for the family how to manage this balance in do something that is good for them, but also respect the autonomy and the decision of the patients. So it is difficult, but as Cathy said, with the help of the GP and also to have a conversation, everyone, and not try to make the patient feel obligated to go, right? Just to try to, you know, make a good environment to talk openly about that.
And I think primary care GPs do an extraordinary job with patients and families, and they've known them for years. And I know they do a lot of work to try and get people through and to try and pave that way for a person by giving them a general review whereby they do a quick memory test and then they send them through to us. And so it's smooth enough. I think it can be. It shouldn't be, even with an anosognosia, I think still it shouldn't be something that distresses the person, but it certainly is a challenge. Yeah.
Great, thank you.
Can I say something?
Yeah, sure, Mike. Yeah.
I do believe that what I've learned is, as a society, we need to move to that where it's a natural discussion to have, and we will only be able to do that when we as a society realise that it's our civil rights to live our lives in whatever way we want to, and as a society, we need to accept the fact that some people are going to have this discussion, and that's going to only come when we as a society change our mindset. And I think all these great moves that are going on, setting up the proper hubs, and is so important, but that only it has to feed into society, and that's, I really believe that.
Yeah, so that whole piece about reducing stigma, and also the fact that there are some, you know, there's an improvement in post-diagnostic supports there as well is great to see. So I'll just finish with some comments coming through. So Simon, thank you. You references a cognitive rehab self-help guide called My Life, My Goals. So Simon shared the link there to that. And there's a comment about, this is going back to the previous comment about cognitive rehabilitation. So somebody said you really need to link with occupational therapy services regarding cognitive rehabilitation. So yeah. Okay. And I don't think there's any other burning questions, just double checking. So what I'll do now is I'll just very quickly launch a poll, just whoever's online, if you wouldn't mind just quickly telling us whether you felt you've learned something. Hopefully you did this morning, and also whether you found the webinar useful or interesting, and again hopefully you did. And while you're doing that, I'd just like to thank our 3 speakers, which I had a sense that this is going to be a very interesting webinar, and it sure was. I really enjoyed it anyway, and hopefully everybody else did tuning in. So thank you to Dr. Raquel Gutiérrez Zúñiga, thank you to Cathy McHale, and thank you to Mike Hanrahan. You all spoke very eloquently on your particular topics, and were great in answering people's questions as well. And thank you very much to everyone who joined us this morning for tuning in. And as I said earlier, a recording of this webinar will be available on our YouTube channel this week. So if you go onto YouTube and look up Dementia Research Network Ireland, you'll find it there. So thanks again.
Thanks, Carol.
You're welcome. And actually, sorry, just what I'll quickly do as well is I'll just share our next webinar details, which I sometimes forget to do. So it's there. Okay, so our next webinar is in March, and it's on Parkinson's disease dementia. And it's normally we run these webinars on Mondays, but this one is going to be on a Wednesday. So just to take note for people who are logging in regularly to these webinars, Wednesday, the 23rd of March at the same time, 11 o'clock. And you can use the same Eventbrite link to register for that. So thanks again, everybody, and have a great day.
Thank you.
Bye.
Bye.
Bye. Thank you.